the next 30 minutes or so, I will address few aspects of screening, diagnosis, and treatment of neonatal hyperbilirubinemia. I have no disclosures, except that I do not know everything, and I may present some of the work of my esteemed colleagues around the world. And when I don't present your work, it has to do with time restraints, not with your valuable work. Well, actually, this slide provides my key messages. Screening is very important. That facilitate early recognition and timely treatment of severe neonatal hyperbilirubinemia. Use transcutaneous devices and maybe an optical-based bilirubin reading, especially in low-resource settings or at home, and educate parents as well. Diagnosis by measurement of serum bilirubin before treatment is essential, and POC, point-of-care devices, show promising results. External quality assessment, also for POC bilirubin devices, is very important to ensure precise and accurate results. And treatment should be based mainly on phototherapy and be done with sufficient irradiance that should be checked before each session. Well, actually, this is my talk, so you can enjoy the rest of the day. But for those who think that I have more interesting information, please hang on. An estimated 1 million newborns worldwide suffer from SNH, necessitating intensive treatment to reduce the risk of death of chronic spectrum disorders, KSD. The incidence of SNH varies between 2 and 42 per 100,000 live-born infants in high-income countries. It depends, at least in part, on the predefined total serum bilirubin levels for this diagnosis. The estimated incidence of SNH is much higher in low-income and middle-income countries. Here, limited access to healthcare facilities and appropriate treatment, which is also limited, threatens the health of thousands of newborn infants. These slides underline the clinical relevance of screening for jaundice identification. Moreover, worldwide, approximately 100,000 infants may die of severe neonatal hyperbilirubinemia each year. Here are some pictures of infants suffering neurological sequelae of severe jaundice. The primary purpose of screening is timely detection of newborns at risk of developing KSD, while diagnostic tests can provide the quantitative confirmation of the extent of jaundice. I will discuss different screening methods, some data on optical bilirubin estimation, and future research areas. Let's first talk about visual assessment. Davidson, in 1949, he noted a wide variability among infants in the correlation between visible jaundice and serum bilirubin level. A majority of infants with concentrations above 70 to 85 micromolar were icteric. In 1996, Kramer systematically correlated dermal zones of jaundice with actual total serum bilirubin values. Here are the dermal zones, and on the y-axis, on the x-axis, sorry, is the serum indirect bilirubin. Again, a wide range. A number of studies evaluated the accuracy and reliability of visual assessment of jaundice. That's been a long-standing way of estimating the severity of hyperbilirubinemia. Correlation coefficients between visual assessment and total serum bilirubin concentrations vary between 0.35 and 0.75. Virginia Moyer and colleagues reconfirmed that it's impossible to estimate total serum bilirubin levels with visual assessment. On the x-axis, the estimated bilirubin is depicted, and on the y-axis, the real serum bilirubin. It's a cloud, not a line. In 2009, Karen and colleagues published a prospective cohort study on approximately 500 term and late preterm infants who had been graded by nurses using the 5-point Kramer scale to determine the maximum cephalocaudal extent of jaundice before discharge. They found that progression correlates poorly with TSB concentrations, the extent of jaundice on the x-axis and the bilirubin levels on the y-axis. Furthermore, the extent of jaundice did not reliably predict the development of significant hyperbilirubinemia, so this scale should not be used by clinicians to estimate total serum bilirubin levels. Dr. Jeffrey Mazels dismissed the efficacy of visual assessment by stating that bilirubin eyes do not exist. It's neither objective nor reliable or accurate, and the inter-observer agreement is poor. To facilitate visual examination and reduce the inter-observer variability, different screening instruments have been developed. One of the first instruments to estimate whether a total serum bilirubin value could be obtained was the so-called icterometer. That's a perspex ruler with 2 or 6, here 5, hues of yellow arranged in a stepwise gradient. And they are related to a range of serum bilirubin levels. So the perspex ruler is pressed on the face, and then the healthcare professional can estimate bilirubin levels. And that's not always very funny. Actually, current guidelines advise not to use the icterometers, but there are some interesting data on novel icterometers. There's the two-color icterometer, the Bili-strip, and the Bili-ruler, Here's the Bili-strip working. Olusanya and colleagues described the diagnostic performance of the Bili-strip. A dark yellow and light yellow icterometer, and that was used by almost 2,500 Nigerian mothers to assess the presence, dark yellow, or absence, light yellow, of severe neonatal hyperbilirubinemia in their infants. The mean transcutaneous concentration for dark yellow, it's about 170 micromolar, was significantly higher than for light yellow. The sensitivity and negative predictive value of the Bili-strip was high, almost 69%, for neonates requiring phototherapy. And important to know that only 1 infant out of 24 who needed phototherapy was missed. In the USA and Bangladesh, a completely renewed icterometer, the Bili-ruler, was tested in about 800 neonates, actually. They were younger than 28 days to identify jaundice. As you can see here, the Bili-ruler has 6 color strips that were developed by processing digital color photographs of newborn infants with different levels of serum bilirubin. The Bili-ruler readings on the nose, they show the best correlation with the transcutaneous bilirubin values, with a correlation coefficient of 0.76. And they also correlated well with total serum bilirubin, the correlation coefficient of 0.78. The sensitivity and specificity for readings higher or equal to 3.5, for TCB higher or equal to about 222, and for TSB higher or equal to 180 micromolar were 90 and 86 versus 85 and 83% respectively, so quite high. And they also show that the inter-rater reliability was also high. So these authors conclude that the Bili-ruler may be used to improve referrals from community or peripheral health centers to higher level facilities with the capacity to test bilirubin in the blood or give phototherapy. In 1978, Hahnemann and Peavy, independently from each other, they demonstrate a non-invasive method to determine serum bilirubin values by spectral reflectance of neonatal skin. And 2 years later, Yamanuchi and colleagues described a linear relation between the bilirubin concentrations and the intensity of the yellowish skin color in human infants of different birth weights. And they predicted that TCB to some extent might replace the TSB determinations. And indeed, TCB devices have become the routine screening tools for neonatal jaundice. They have several advantages. It is non-invasive, fast, easy to learn, and very user and patient friendly. The levels of TCB are estimated from the yellowish discoloration of the skin and the subcutaneous tissue by measuring the differences in optical densities for a light of different wavelengths. Actually, dark pigmentation of the skin may potentially confound the light reflectance. Manufacturers have developed different methodologies to correct and to minimize the effect of skin pigmentation. So the TCB values provide a reasonable estimate of the serum bilirubin levels in healthy newborns with correlation coefficients ranging from 0.7 to 0.97. And the American Agency of Pediatrics, AAP, the guidelines suggest using TCB screening for neonatal jaundice prior to discharge. But the use of TCB varies among nurseries, even within one country, from none to selective or universal screening. They have some disadvantages. They are rather expensive, approximately $8,000. The measuring scales of the TCB instruments are limited. They provide no readings above 340 micromolar. And the inter-device differences may be as high as 65 micromolar. So maybe you should use a single TCB instrument per patient to evaluate the TCB over time. Moreover, these instruments may also overestimate TSB at low values and underestimate TSB at high values. TCB is also often overestimated. TCB also overestimates TSB in African American newborns compared with newborns of other races. Here you see the TCB using preterm neonates. It's a brand called Keygen, nothing to disclose, by the way. And they used it in preterm infants. The manual said you should use it in term infants. And you can see that the overall person correlation coefficient was good, but in infants less than 32 weeks gestation, it was very bad, 0.5. The accuracy of TCB in infants receiving phototherapy is less, and that's probably due to skin bleaching. Phototherapy enhances the well-known underestimation of TSB by TCB in preterm infants, even when measured on an unexposed area of skin in the diaper area. You can see here 3 Blen-Eltman plots before, during, and after phototherapy. We measured during phototherapy, but also before and after in the diaper area, so that it was covered from light. And before phototherapy, there is a bias of about 50 micromolar, but it increases to 60 during and remains after phototherapy. So the underestimation of TSB before phototherapy was significantly lower, approximately 44. than the underestimation during 61 and after phototherapy 63. And in analogy to this, a Canadian research group published similar data last week and concluded that the underestimation of TSB after the initiation of phototherapy warrants the use of TSB for clinical decision making after the initiation of phototherapy. So currently in the Netherlands, we do not use TCB under phototherapy, and also not in the first 24 hours after treatment has stopped. So the TCB values, they inform the healthcare professional about two questions. And that was quoted from Measles. Should I worry about this infant? And should I obtain a TSB in this infant? To counter the shortcomings of transcutaneous devices, various decision rules on TCB cutoff levels, that is, when to obtain a TSB, have been proposed to minimize the risk of missing high TSB levels. One rule to correct for underestimation is to obtain a TSB when the TCB value is higher than the TSB of the phototherapy threshold minus 50. That generally works well in our clinic. The advantages and proven reliability justify the use of transcutaneous bilirubin to screen for SNH. Okundu, Botani and colleagues, they performed a randomized controlled trial in almost 2,000 infants to test the clinical benefits of TCB screening of healthy newborns before discharge for the outcomes of readmission for jaundice and severe hyperbilirubinemia. So they compared pre-discharge TCB screening with visual assessment for jaundice in apparently healthy newborns at a public tertiary hospital in Cape Town, South Africa. They demonstrated a significant reduction in the rate of readmission for jaundice with a risk ratio of 0.25. And they also noted a reduction in the incidence of severe hyperbilirubinemia with a relative risk of 0.27. So it's a good thing to do. Universal TCB screening works. A novel method to estimate TSB levels and to detect severely neonatal jaundice is using the camera on a mobile phone in conjunction with advanced imaging processing techniques with red, green, and blue pixel color analysis and machine learning. Given the widespread use of smartphones, also in low and middle income countries, these smartphone applications, apps, may facilitate neonatal jaundice screening. These apps use the yellowish discoloration of the newborn skin or whites of the eye, the sclerae. A color calibration card that you saw in the former slide helps to attenuate variations in the lighting conditions of the surrounding environment, and it facilitates imaging capture and data extraction. By using this card, various brands of smartphones with different lens qualities can be calibrated. In studies that compare smartphone-based optical bilirubin estimates with TSB, correlation coefficients vary between 0.48 and 0.91 on the skin and 0.73, 0.86 on the sclerae. Although the sclerae are not influenced by skin pigmentation, mean differences between optical bilirubin estimates from skin or from sclerae and TSB, as well as diagnostic accuracies, are more or less comparable. Taylor and colleagues reported a mean difference between the bilirubin bilirubin and TSB of 0.17 micromolar. So that's 2 micromolar. That's even less than, sorry, that's 0.17 micromolar actually. Almost 92% of the bilirubin values were within the 50 micromolar of the paired TSB levels. I will show that in the next slide. and sensitivity was very high, 100%. With a specificity of 75% for identifying TSB higher than 291 micromolar. So there is a very small mean difference, good correlation between the TSB and the Bilichem image. Very small difference, 0.71. I'm sorry, I'm a little bit distracted because the results look familiar. This is not from Taylor, but this is from Anders Arne and his group from Norway. They reported the mean difference between the picture's image on the y-axis and the TSB and the x-axis of similar to Taylor's ones, minus 0.2 micromolar. Sensitivity was 100% and specificity was 69% for identifying TSB higher than 250 micromolar. So you can see the Blend-Eltman curve, very small mean difference. There is a wide range of the level of agreement, similar to Taylor results. As no single intervention is likely to be sufficient, according to Watchko, to prevent a severe neonatal hyperbilirubinemia and to reduce the burden of bilirubin neurotoxicity, other areas are also of interest to study. Wenberg and colleagues of the Stop Coronary in Nigeria consortium demonstrated that maternal instruction on neonatal jaundice and timely care seeking, whenever jaundice is suspected, was associated with a reduction of acute bilirubin encephalopathy. So here the models that received training, you had a mean bilirubin at admission of about 340 micromolar, 4 developed acute bilirubin encephalopathy, whereas the model that did not receive prenatal training had very high, much higher levels of bilirubin at admission, and almost 50% developed ABE. As this points to the need for parental instruction on jaundice, it seems clear that future projects on the prevention of SNH should encompass parental instruction, irrespective of the screening method used. In July 2020, actually within 10 days, the so-called Beat Jaundice at Home study, Better Assessment of Jaundice at Home study, will start in the Netherlands. This project is led by Lauren Westenberg and Jasper Been, and we will study 3 screening methods for neonatal hyperbilirubinemia at home in approximately 2,000 neonates with a gestational age of at least 35 weeks. The screening methods are transcutaneous devices from Draeger, the AM105, a commercial available point of care test for total bilirubin, that's the Bili stick, and a smartphone application, the Beatrix application from the Beatrix group in Norway. Among well babies cared for at home during day 2 and 8 at live, the proposed project will determine the user convenience and effectiveness of universal TCB screening as an addition to visual inspection, that's the care as usual, to detect hyperbilirubinemia requiring treatment as a primary outcome, and also reduce the need for heel pricks to quantify TSB as a secondary outcome. So here's the flow chart that will be handed over to the midwives, and they will do these they will perform these screening tests, and in certain subgroups there will be assessment of the serum bilirubin level, and then there will also be a point of care assessment. So very exciting what this will bring to us. Well, while awaiting the results of this study and other studies, of course, we expect that in the near future on artificial intelligence, machine learning technology, and biometrics may play an important role in the early recognition of SNH and reduction in acute bilirubin encephalopathy and current spectrum disorders. Probably another research niche will be the application of wireless wearable biosensors that allow for continuous non-invasive monitoring of transcutaneous bilirubin. Here you see the Japanese group in Amori who have developed such a device for the head of a newborn baby. So this was approximately the first half of my talk, and I will be happy to answer some questions and answer. The next part will be on diagnosis and treatment.
Okay, thank you. There's any question, or shall we postpone all the questions at the end of the presentation?
Well, this is Jeffrey Mazels. Can I ask a question, Claudio?
Hi, Jeff. Go ahead.
Christian, you know, we read about the smartphone diagnosis of jaundice as a very promising technique, and it was first described actually even more than 4 years ago by Taylor. And since then, there have been a couple of papers from Japan demonstrating very good results with the smartphone. But my question is, what has happened to it? Because we've heard nothing about the smartphone technique really in the last 4 or 5 years. There's been no further papers, no further publications. It strikes me as that they've struck a problem that they haven't been able to solve, to make it commercially available in neonatal units. Do you have any updated information on the smartphone technique?
Well, actually, that's a good point, because the Taylor group, they published the results actually indeed 4 years ago, and then it stopped. But I think the most recent publication was from an English group. That was a research paper on the yellowish discoloration of the sclerae. And before that, in 2020, Anders Aune and colleagues, they published a relatively small study in the Acta Pediatrica, but they want to expand the set of data before going commercial. I'm not sure whether Anders is present here, but he may well comment on it, or people from the US familiar with the smartphone techniques.
This is John Watchko calling. I can tell you that James Taylor left the UW and went to Google to help further refine the techniques. And I don't know where things are, but I know they're having major issues with the FDA in terms of getting approval. It has to be, I mean, the criteria for approval is quite rigorous, and it has to be foolproof, absolutely foolproof. And that has been the challenge, as I understand it.
Okay. Yeah, from Anders, not sure again whether he's here, but I demonstrate one figure with quite large range of level of agreement, and well, maybe wider than for the TCB devices, but we might consider to construct another decision rule, for example, not adding 50, but adding 80 micromolar to the estimated optical value. So we need some more data, and I hope the Dutch data will also provide and contribute to.
Exactly my point. I think that the Dutch data, the Dutch study will be the first one strictly and correctly comparing 3 different approaches. And I think that this may provide us an operational answer.
I hope so. Yeah.
Yep. Okay. Any other question? Well, if not, you can proceed with the next piece of your presentation.
Thank you. You all know that bilirubin measurements in blood remain the gold standard for diagnosis and treatment of severe neonatal hyperbilirubinemia. A vast number of methods to determine bilirubin in human serum has been developed. It was first reported in 1858 by Beatrix, there was the chameleon reaction. There are different instruments with specific properties, as you can see in this table. It's important that manufacturers should make the TSB test results traceable to the internationally endorsed reference measurement system, and they should also ensure permissible limits of measurement uncertainty. It should also be done actually for the novel diagnostic point of care bilirubin devices. Over the past decades, bilirubin measurement for severe neonatal hyperbilirubinemia identification has constituted a major challenge. The guidelines, they rely heavily on the ability of the physician to recognize jaundice on the one hand, and also on the measurement of and precise and accurate measurements of serum total bilirubin. But according to Dumas and Lowe, bilirubin determinations are the most notoriously unreliable of any in clinical chemistry. In 2010, in the Netherlands, Cobart and colleagues analyzed the accuracy of TSB levels nationwide as measured by the most commonly used multi-parameter instruments and in vitro diagnostic devices. Two value-assigned specimens were measured in almost 200 labs and also in-house by the IVD manufacturers. This allows the accuracy of results to be assessed and to be compared to the target values assigned with an internationally recognized reference method. The red dots are the values that are endorsed by the reference methods, 28 and 70. As you can see, the interlaboratory and also intra-laboratory, so the inaccuracy of TSB levels observed among manufacturers and individual laboratories were substantial. Stars represent here different manufacturers, and squares different labs. Was again done in 2019, 2020, and there are few changes. Maybe it's a little bit better, but it indicates that the concept of so-called metrological traceability, which leads to exchangeable TSB results, whether it's performed here in the US or in Italy, was not uniformly adapted. So external quality assessment, they play an important role in revealing inaccuracies in diagnostic bilirubin measurements. When my colleague Peter Dijk and I reveals that in the external quality assessment samples, they were spiked with bilirubin levels less than 80 micromolar, we set out a study to overcome this. Together with our colleagues from the lab, we sent solutions that were spiked with unconjugated bilirubin to create bilirubin concentrations ranging from 100 to 500 micromolar. And we demonstrated that interlaboratory variability increased with increasing bilirubin concentrations. So there's a rather large range of measured bilirubin, whereas it should be 500, sometimes it's 400, sometimes even 600. We demonstrated that the variances at, for example, 250, but also at 450 were comparable. There is a large interlab variability. And these are data from 2019. And I have no data of this year, but what I heard from the lab colleagues, it's more or less similar. So that's still room for improvement. In the NICU, it's common to find blood gas analyzer instruments that can also measure bilirubin. The comparability of blood gas analysis derived bilirubin levels and bilirubin levels by routine laboratory techniques was assessed by several research groups. It was done by Lano and published in 2018. And results showed a good correlation in comparison to a routine lab methods, and a small difference about this was minus 1.5 micromolar, and the other was plus 5 or so. But the 95% limits of agreement, they were rather wide, 40 to 50 micromolar. So also good for these devices to take part in the routinely done equally assessment schemes. So there's an ongoing need for specific quality assessment schemes for neonatal values. And this could lead to recalibration of the bilirubin assays. And it's also important to cooperate between doctors and clinical chemists, the lab people. Then the POC point of care methods. They appear to be an effective alternative for the measurement of bilirubin in newborns, particularly when the conventional methods are not available or inaccessible. One of the main advantages of the portable POC bilirubin instruments is that the turnaround time is much shorter. So the interval between collecting the sample and reporting the bilirubin results. It varies, or it is about 2 minutes versus approximately 2 hours in one study of BO. And that's also, I think, what we experience in clinical practice. Actually, this may also reduce the delay between the assessment and hospital admission, as has been assessed by a Dutch group working on the substandard factors in infants with bilirubin levels above exchange levels. Several hours of delay between the first recognition, the heel prick, and the lab results exist. So POC methods will be effective here, hopefully. In 2017, Kihi and colleagues reported validation data of a new screening device, the Bili-ruler, in about 100 blood samples of 67 newborn infants between the day of birth and 24 days. The Bili-ruler is a battery-powered device, low cost, that quantifies their bilirubin levels from whole blood that's applied to a lateral flow charge that's put into this device. The study showed actually a high correlation with an correlation coefficient Pearson of 0.97 of the Bili-ruler against a benchtop bilirubinometer, the Unistat Reichert actually, with a TSB range from almost 90 to 390 micromolar. Panel B here shows that the mean bias between the benchtop TSB and the Bili-ruler bilirubin readings was 5 micromolar, the red dotted line, with 95% of level of agreements of minus 29 to 38 micromolar. Panel C shows that 86% of the total samples deviated less than 17 micromolar from the lab standard. So pretty good results, published in 2017. In recent years, the bilirubin measurements by another POC method on capillary or venous blood samples has become available with the Bili-ruler system. Currently, the Bili-ruler 2 is running. This direct method consists of a handheld rechargeable battery reflectance reader and some test strips composed of a blood plasma separator coupled with a nitrocellulose membrane. From the various studies, I will briefly discuss one. That's the one published in 2018 by Greco and colleagues. They reported the performance of the Bili-ruler 1.0 for identifying severely neonatal jaundice in a multi-country approach in almost 2,000 infants. So that's very respectable number. They showed actually that the bilirubin level measured by the Bili stick was not significantly different from the laboratory TSB values in all 4 countries. There was, however, just like the other methods, a rather wide level of agreement. So this slide summarizes a few pros and cons of POC bilirubin measurements. It's simple, it's rapid, user-friendly, and very low cost. And the limitations, they may be overcome in newer versions, that sometimes there's an error reading, sometimes there's a false low values, especially in high humid climates. It has been published by Tielemans. And it should also be said there's a lack of standardized TSB measurement methods. So the gold standard in all these studies, which show some wide level of agreement range, it's not always properly described. And there is an effect of high hematocrits that also may have been overcome in the newer version. So very much looking forward to use this device in the Beat Jaundice study. The newer POC methods consists of combination of a paper and smartphone. Tatabatabe and colleagues reported fast and reproducible TSB measurements in whole blood with a smartphone-based bilirubin assay kit using this paper. And Dick Wenberg, as you well know, described a so-called Bili-pig smartphone assay as a component of a digital system that facilitates, among others, education and also diagnosis of neonatal jaundice. So 1 drop of blood, and then a Photoshop does the rest. And he showed that the Bili-pig has a good correlation with laboratory bilirubin values, up to a bilirubin level of 25 milligrams per deciliter, with a level of agreement range of approximately 50 micromolar. So looking forward to see and hear more about this interesting device. In summary, accurate and precise bilirubin measurements are important as jaundice occurs worldwide and treatment is bilirubin based. Commutable quality control samples with age-specific ranges of bilirubin should be used to monitor bilirubin measurements. The point of care bilirubin measurements are very promising and being studied. So the last part is about treatment of hyperbilirubinemia. I end with a few remarks on phototherapy. There are many more options, but phototherapy is key in treatment of jaundiced infants. Thor Hansen and colleagues have written an excellent historical review on phototherapy that I recommend you to read. And I remember Henk Vreeman, a senior research scientist at Stanford University, who said it took some time for the world to realize the significance of phototherapy, but it's now the global standard of care for jaundiced infants. So turn on the lights, please. 3 to 9% of term newborns are treated with phototherapy. And data from NICUs reveal that the frequency of phototherapy varies between countries and depends on birth weight and gestational age. In this publication of Mercury, Mazels et al., it can be seen that for the very low birth weight infants, almost everyone is treated. And depending on the guidelines used, in Norway, it is also very often used. And in infants who have a higher birth weight, Norway, approximately 44% is eliminated, whereas in the US, 80%. And actually, in our NICU, data from 14 years ago, almost 88% receive phototherapy of the infants with a gestational age of 29 weeks and a birth weight of 1,250 grams. So it's a little bit in between, more like the US data probably. The benefits of phototherapy is mainly that fewer infants receive exchange transfusions. Here are data of one of the earliest National Institute of Child Health and Human Development phototherapy trial in the 70s. This data has been published by Brown in 1985. In the phototherapy group, the number of exchange transfusions is lower for infants less than 2,500 grams, whereas it was not significantly different, about a little bit lower in infants with a birth weight over 2,500 grams. Watchko and Mazels published these data almost 20 years ago and demonstrated that phototherapy reduced ET rate, that is, exchange transfusions were rarely performed in a single center. And Steiner et al. Contributed with the same, showing that the same trend, that less exchange transfusions are occurring. And that's due to phototherapy, at least this should be suggested. Newman and colleagues, they published interesting paper in which they calculated the number needed to treat to prevent an exchange transfusion. And these numbers varied widely. The mean values were 220 for boys and 300 for girls, but there was a wide range for female infants of 41 weeks, older than 3 days. Almost 3,000, more than 3,000 infants need to be treated. And for boys less than 1 day old, 10. So the number needed to treat to prevent an exchange transfusion varies considerably across different infant subgroups. The effectivity of phototherapy is quantified in part by the intensity of irradiance that a light source can deliver and also the skin area exposed. Their product, irradiance times area exposed, is called the spectral power. Here you see a preterm who is covered to a large extent, thus reducing the illuminated body surface area, something to be aware of. Using a LED phototherapy device, Van Borg and colleagues, they observed a linear dose-response relationship between irradiance in the range of 20 to 50 microwatt per square centimeter per nanometer, and a decrease in the total serum bilirubin levels over the day. We set out a study a few years ago to measure irradiance level in Dutch NICUs. Here you see a model with 5 and 3 measurement points for overhead and underneath phototherapy devices. So the current recommendations of the AAP for phototherapy state that a conventional phototherapy device should deliver a spectral irradiance of minimal 10 microwatt per square centimeter per nanometer. And intensive phototherapy should have a spectral irradiance of at least 30 microwatt per square centimeter per nanometer. It should be delivered to as much of the infant's body surface area as possible. Van Imhoff found that a startling 50% of PT devices in the Netherlands failed to meet the minimum recommended irradiance level. The distances between the phototherapy device and silhouette model and infant were rather large and larger than recommended by the manufacturers. And there's an inverse relation between these two parameters. So we brought this to the attention of the NICU staff and did a follow-up study a few years later. Renewed attention was focused on the website Baby Ziet Geel, in English Baby Looks Yellow, and its recommendations on the application of phototherapy, including the importance of an adequate distance between device and patient. And we noted in a follow-up study, while the irradiance of the Dutch phototherapy devices still varied, it had improved markedly from the previously reported results. both for the overhead and also for the underneath devices. The distances between the device and infants were shorter, probably contributing to better irradiation levels. And also there were more LED-based devices. More or less similar results were obtained in secondary hospitals. A recent USA study from Borden and colleagues concluded that intensive phototherapy was suboptimal for 62% of devices, 39 in 7 hospitals. And in Java, Indonesia, our PhD student, Mahendra-3 Arif Sampurna, measured 77 combinations of 20 different phototherapy devices in 17 hospitals. In 9 hospitals, the irradiance levels were less than required for standard phototherapy, so less than 10. And in 8 hospitals, irradiance levels failed to reach the levels for intensive phototherapy, less than 30. 3 hospitals provided very high irradiance levels, more than 50. Here you can see a lucky Indonesian pediatrician surrounded by his wife and children, and he will defend his PhD entitled Improving the Management of Hyperbilirubinemia in a Limited Resource Area on July 5th in the Netherlands. So we and others have demonstrated that many hospitals do not always deliver sufficient phototherapy irradiance. And to increase awareness of too low irradiance, we should start to measure irradiance, like we measure the dose of antibiotics, like we measure the percentage of oxygen. We never say give the child a spoon of antibiotics, or well, turn on the knob of the oxygen to the right, then the child will receive more. No, we really should measure it. The light source and the irradiance meter ideally need to be matched carefully by the manufacturer and should be provided by the manufacturer. This recommendation is not new. To overcome the shortcoming in treatment of infants with neonatal hyperbilirubinemia, we really should measure phototherapy irradiance before and ideally also during each session. So to end this lecture, this is the same slide as the third one. Screening is very important. Use transcutaneous device and maybe an optical-based bilirubin reading, and educate parents on the risk of jaundice. Diagnosis by measurements of serum bilirubin is essential, and point-of-care devices show promising results. External quality assessment for all devices is very important, and treatment should be done with sufficient irradiance that should be checked before and maybe also during each session. Thank you for your attention.
Thank you very much for your presentation. Very exciting. Now it's time for question and comments. Please, don't be shy. Is there anyone asking for some? Let me ask a question, Chris. I think that you pointed out correctly that we need to have a quick decision how to treat, if and how to treat a jaundice baby. And there's the point of care, all the new devices related to the smartphones, if reliable, can provide us the answer. Question is, there is a shift between treatment, diagnosis from lab, centralized lab to home. Is there any reason why we need to also shift the treatment from hospital to home by taking advantage of the portable point of care phototherapy bed? I'd like to have your comment.
Yeah, that's a good point. We are aware that some hospitals in the Netherlands, I think around 4 or 5 of 100, already provide home phototherapy. And there has been recent data that a home phototherapy for uncomplicated jaundice, so not for infants with hemolytic jaundice based on blood group incompatibility. It is also safe. Readmission rates are very low. So probably that's going to be increasingly used. Actually, we are planning to ask for funding a study that's called the Treat Jaundice at Home study. To study what are the barriers and what are the facilitators to perform such treatment at home, because we want to keep infants out of the hospital when it's possible. And I think it is possible for a selected group of apparently healthy term infants.
Well, I think that this is important in order to give some perspective. Is there any other question or comment? Really?
I have a question. I'll ask a question.
Right.
It's just more of a curiosity, more than a question. Do you know if the Bili spec has been used in experimental animals?
I am not aware of it. No, I've only read data on humans, actually, neonates. Yeah. Maybe one of the audience knows it, but I'm not aware that they tested it in animals.
No.
What's the background of your question, if I may ask?
What's that? You broke up on me. What was your question?
I just wonder why you want to know it.
It'd be a lot easier to measure plasma bilirubin in animals.
Well, let me tell you that working with rats is not that easy to work with bilirubin, because it's, I mean, for instance, the BF, the technique used by Chuck Alford, the peroxidase technique, doesn't work in rat plasma. No one knows why. I had a long discussion several times with Chuck, and we decided to run a lot of experiments when Chuck was here, and we never succeed to understand. So it's, I mean, I think the Bili-spec can be used for measurement bilirubin in animals. For sure, Bili-stick is easily applicable to rats. We're using in our lab extensively.
I would just like.
Sorry, this is Cynthia Bearer. I have a really naive question. Every time I submit a grant to the NIH, I always have one or two reviewers saying bilirubin isn't a problem. You know, we get scored on significance, environment, investigators, research strategy, innovation. And every single time somebody says that bilirubin isn't a problem. How do you address that?
Well, I think there are lots of data coming from the sub-Saharan countries that it's a major problem there, and it is a great problem, but for fewer infants in countries who call themselves high income countries. I mean, I didn't show you the video, but that was with a voiceover from Stephen Shapiro from the parents of infants and children with chronic icterus. So it's a major burden in every country. But the counter side is that in a majority of infants, it's well, a transient, maybe even beneficial, and not harmful. So that's and there are good therapies when you start timely. So I think that's one of the well, that's one of the backgrounds, or the background that the major criticasters say it is not a problem at all. I'm not sure how to tackle that. I myself have also some funding well, problems, because the chronic icterus are really small, and actually we do not register them formally. So it's also our own fault. So we should start with a more proper follow-up to create own data, national data, and compare it to international data. That's the point where we are now. by also incorporating the follow-up in the guidelines. And we hope to revise the guidelines, end the process this year, in which the follow-up is also recommended. Doing that better, maybe the size of the problem also in Netherlands becomes more clear. But it's a good point, Cynthia. Maybe other persons have other solutions. We're happy to hear them.
I wonder if we couldn't get together and publish something about the significance of hyperbilirubinemia.
Well, we have published about it, Cynthia. The facts are quite well established. You're right. It's the incidence of connectorous or brain damaged babies is very, very small in high resource countries. You know, in the Western world, we probably have something of the incidence somewhere between 1 in 100,000 to 1 in 200,000 live births develop connectorous. Now, in the United States, for example, every year we have 8,000 new cases of cerebral palsy every year. 8,000. These are not the result of the obstetrician failing to do cesarean section within 10 seconds of seeing the first late deceleration, but these are due to mainly intrauterine events over which neither the obstetrician nor the pediatrician has any control. Nevertheless, we have 8,000 new cases of cerebral palsy. We probably only have maybe 20 new cases of cerebral palsy due to connectorous. The difference between the two is that connectorous should be, not entirely, but should be mostly preventable. Mostly. We haven't worked out a way of preventing it entirely. That's why we still agonize about it. So there still are cases in which it's a condition which could be easily treated and prevented if one knew about it at the right time and intervened at the right time. But unfortunately, there are conditions such as G6PD deficiency, where you have a baby with a bilirubin level of 8 on Monday morning, and on Tuesday morning the bilirubin level is 42. For nobody, and there's no obvious explanation for that, except there's some hemolytic episode that has occurred. Nobody knows why, nobody knows what the trigger is, but these events still occur. In fact, in the United States today, that's probably the major reason for connectors is G6PD deficiency, with this remarkable fulminant increase in bilirubin levels in a number of hours, which occurs, which is uncontrolled. So it still is occurring, and you know, 8 out of 10 full-term babies are jaundice. People don't understand. If you look at babies in the first week of their life carefully enough, 8 out of 10 of them are jaundice. Now, they're probably supposed to be jaundice because it protected them against oxidative stress that they've suffered from emerging from a fetal life with a PO2 of about 28 to a fetal life with a PO2 of 100. So presumably there's some oxidative stress, and maybe that's the reason why babies are born with jaundice. We don't really know that, if you want to quote teleology. But it's a very, very common problem, and it requires a tremendous amount of time on the part of pediatricians, family practitioners, and parents to make sure that these very, very few babies don't develop extremely high bilirubin levels. I mean, that's the best we can do. Now, as Christian correctly pointed out, if you go to countries like Nigeria or Kenya or other parts of sub-Saharan Africa, or even in China, the incidence of brain-damaged babies with connectors is substantial. It is substantial. It's not a minimal issue at all. And so in countries that are not blessed with the kind of healthcare systems that we have in these developed countries, where babies are monitored and people are worried about them and bring them into procedure, they get their bilirubin levels measured, so on, so on, and so on and so forth. I mean, in parts of Nigeria, there's not even a way of determining whether the mother is Rh negative before she delivers her baby. So when you're dealing with countries like that, we still have a problem that is quite significant. In the developed countries, the problem itself, its magnitude, is not as significant, but the amount of time and energy that has to be spent on monitoring is very significant. And we're hoping to perhaps reduce those aspects of bilirubin care, that is, spend less time and less money where it's not needed. But it's not that easy to do that. With something like point-of-care measurements or home measurements or transcutaneous measurements or new developments of a kind of billimeter that you can use at home or a smartphone, something like that, which would make it easier to take care of these babies without having to be seen by a physician, would make a tremendous difference in the high resource countries in the management of jaundice babies.
I want to make one comment to Cynthia, one comment to Jeff. I mean, the comment to Cynthia is, I agree. I mean, when you talk bilirubin, bilirubin is garbage for a lot of people. Although they don't realize, I'm pretty sure that Terry agrees with me that bilirubin is like a hormone. It makes a lot of different biological effects, not only in the liver, but throughout the body. And I think this is one message we need to develop and to deliver. But according to the comment by Jeff, I agree. But there's one additional issue. I'm not a pediatrician. I'm not a neonatologist. But I learned working with you guys, there's one thing which is crucial is why some newborns develop damage at, let's say, 30 micromolar, 30 milligram per deciliter. Others do not develop any damage at 40. BF may be one of the explanation. And we crave to have a simple method to measure BF. Probably there's something in the horizon, and we still need to have confirmation. But another issue, which is still very important, in my opinion, that's where we need to get together and try to solve, is the genetic background. Because I think there are some genes, and we have a data from rats, rather convincing, coming from our lab. Sylvia is here with us, and then she's the running leader of this project together with Christina. There are some genetic background at which you are protected, and other you are more susceptible to damage. And you can come out with the 10 genes, which telling us whether a newborn is protected or is keen to get the damage. This could be a major step forward. This is the future. This is where we need to get together and try to raise money to do some research. And I agree with Cynthia that when you apply for NIH or European grants, they say, well, that's blah, 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 which is not the case. Then fighting ignorance is very difficult. Any additional comment? No. If not, Chris, thank you very much. You did an excellent job, and get in touch. And we're looking forward to, probably and possibly within when the data in the Dutch study will be over, will be collected, you can tell us the results.
Thank you. Thank you. Thank you. Bye.
Bye-bye.
Bye.
Take care.